Okay, everyone. Well, thank you so much for joining us today. Welcome to ADA's webinar for mental health professionals, nutraceuticals, and herbs for depression and anxiety. We are so excited to have Dr. David Michelon here with us today. Just please note this webinar is being recorded, and for those who applied for CECME credit, you will receive an email with the link and instructions after this session. You will be able to ask questions at the end of the webinar during the dedicated Q&A session. So please feel free to put your questions into the chat or the Q&A throughout the session, and we will answer them at the end of the session. My name is Sasha Sicard. I'll be your host today, and I'd like to introduce Dr. David Michelon. He is the Joyce Root Tedlow Professor of Psychiatry at Harvard Medical School and the Director of Depression and Clinical Research Program at MGH. His research has focused on various areas of depression, including psychopharmacology and complementary alternative medicine. He has published more than 300 articles, way to go, Dr. Michelon, a textbook on natural medications, and a guide to treatments. In addition to his research, he also supervises and teaches at McLean Psychiatry residents and Harvard medical students. Dr. Michelon, thank you so much for having us today, for joining us to share your expertise. You can go ahead and share your screen and just let's get this ball rolling.
Thank you, Sasha, and my thanks. This presentation, as the title says, will cover some of the more popular nutraceuticals and herbal remedies that are being used for treating depression and anxiety. I'll review a few things. First of all, my research has been funded by various organizations, and usually in the form of a donated drug or placebo, or in the case of our whole body hyperthermia work, the device itself. And my work through the Clinical Trials Network Institute is funded by various private companies. So let's review the objectives of this seminar. As the attendees, my hope would be that by the end of the presentation, you'll come away with a good understanding of what exactly are these nutraceuticals and popular herbal remedies, and why are they so popular in the first place. You should have a good sense of the indications for these, the recommended doses, what we know about how efficacious they are, and a number of safety considerations associated with these complementary therapies. And as a result, you should have a good appreciation of how these therapies can be used in the treatment armamentarium for all mental health professionals. Okay, let me begin by reviewing a little bit about nutraceuticals and herbal remedies, and what are the pros and cons that we should consider as clinicians. First, some definitions. A nutraceutical, what exactly is that? Technically, it's defined as a foodstuff, which means fortified food or dietary supplement that provides some sort of health benefit. That's the definition. Nutraceuticals and herbal remedies are big business. In 2017, there was a survey done by the National Center for Complementary and Integrative Health and the Centers for Disease Control. They found that about 30% of Americans use some sort of complementary practice or product, and are paying collectively about $30 billion a year in out-of-pocket costs. So a lot of money, and this market is growing. The global market in 2017 was about 209 billion. And in about 3 years, it will be expected to grow to something like 373 billion. The reasons for these products being so popular are fairly straightforward. They're easy to access because they don't require a physician's prescription. And they're generally better tolerated compared to standard antidepressants or anxiolytics. They generally have fewer and less severe side effects. As we know in the field of depression and anxiety, our treatments, although effective, aren't necessarily good for everyone. And there are many people with treatment-resistant depression or anxiety who haven't responded to standard therapies. And for many, turning to some of these complementary remedies can be a good option. Unfortunately, we don't have a large body of systematic, rigorous research done with large samples and the appropriate controls. And so consequently, we don't have as good an understanding of how these natural remedies may work compared to FDA-approved drugs that require more rigorous testing before they get approved. Another problem is that a lot of people mistakenly assume that just because something is natural and available over the counter, that it's automatically safe, and that's not the case. As you will hear, there have been cases of toxic reactions occurring, other serious adverse effects, and drug-herb interactions. And so as clinicians, we need to be cautious about them. Another problem is that because many of these remedies are marketed by different companies, they may have different ingredients in their preparations, different degrees of purity, and so forth. So brand A of a particular herbal remedy may be delivering a different amount of active product compared to brand B. Finally, most of these treatments are not covered by insurance because they're not approved by the FDA. And so people have to pay out of pocket for them. And therefore, they have to consider the out-of-pocket cost, which for many people may be prohibitive. I'll start by talking now about one of the most popular herbal remedies for depression, St. John's wort, also known as Hypericum perforatum. You see a nice couple of pictures of a yellow flower there. So St. John's wort is actually very well studied for a natural remedy. There's about 40 published clinical trials in the literature, including many comparisons with tricyclic antidepressants and SSRIs. And in recent years, many systematic reviews and meta-analyses have emerged. By and large, the body of work suggests that St. John's wort is superior to placebo and about equivalent to low-dose tricyclic antidepressants, as well as pretty comparable to SSRIs. There are fewer studies with SSRIs than with TCAs. By and large, the studies suggest better tolerability with St. John's wort. Generally, fewer patients will discontinue St. John's wort because of adverse effects. On the other hand, we don't know very much as to how well it may work in more severe depression, since most of the studies tend to take patients with mild to moderate depression. There's also not very good reporting of adverse effects in all of these studies, particularly with some of the less common ones. How does St. John's wort work? It's thought that there are two active products, hypericin and hyperforin, that interact with the hypothalamic pituitary adrenal axis to reduce cytokine production, essentially dampening some inflammatory activity that could be associated with the development of depression. As far as safety, St. John's wort is generally considered safe, but there are a number of caveats. Most side effects are mild. They may include a dry mouth, dizziness, and constipation, which we'll see with most antidepressants. But there are some more serious side effects. For example, phototoxicity or sensitivity to sunlight that can make people more vulnerable to sunburn. Also, there have been cases of cycling to mania in individuals with bipolar disorder who were treating the depressive phase with St. John's wort. We recommend that if you're taking St. John's wort and say going to the beach, wear plenty of sunscreen, wear a hat to protect yourself. And then if St. John's wort is combined with SSRIs, which is unfortunately a common practice where a patient may buy St. John's wort over the counter without telling their psychiatrist and add it to an SSRI regimen, there have been cases of serotonin syndrome that may occur. On the right of the slide, you see the mnemonic for serotonin syndrome, shivers. There are actually many mnemonics. This is a nice one: shivering, hyperreflexia, increased temperature, and so forth. This is a potentially fatal complication if left unmanaged. It occurs because St. John's wort has a mild degree of monoamine oxidase inhibitor activity. You don't need to follow the MAOI diet if you're taking St. John's wort, but you do need to be cautious as far as combinations. Another concern is that St. John's wort induces the cytochrome P453A4 form, which in turn reduces the activity of a number of drugs. I list them here. There are many: warfarin, cyclosporin, oral contraceptives, some other psychiatric medications, and some of the HIV drugs. So obviously, caution is needed in individuals with HIV or cancer and people who have received transplants. There have been cases of transplant rejection as a result of decreased activity of some of the immunosuppressant drugs. As far as pregnancy, there is some preliminary evidence suggesting safety in pregnancy, but we still advise caution for any pregnant women because we just don't know enough. So the recommendations for St. John's wort, I would say the results are encouraging but inconsistent. Probably best to use in cases of mild to moderate depression. Certainly do not combine it with SSRIs or with any of the other listed medications. The recommended doses range from as little as 300 to as much as 1,800 milligrams a day. Doses are typically divided on a 2 or 3 times a day basis. But keep in mind, different preparations may vary in potency. So if a patient switches from brand A to brand B, there may be some loss of efficacy or increase in side effects depending on how potent preparation is. Let's go on to the next natural antidepressant, S-adenosine methionine, or SAM. On the left of the screen, you see a chemical drawing of SAMe, and I call your attention to this methyl or CH3 group under the arrow. SAMe functions as a methyl donor in more than 100 physiological reactions in all living beings. We all make SAMe. This particular methyl group is very important because it helps to promote neurotransmitter synthesis as well as other functions, gene regulation, post-translational modifications, and other things like that. It's very important in the folate and methylation cycles. You see it's dependent on levels of folic acid, which is obtained in the diet, as well as vitamin B12, you see here. As a result of various interconversions, SAMe is produced, and this in turn leads to the synthesis of DNA, proteins, phospholipids, and neurotransmitters. It's believed that by providing higher levels of SAMe, we can stimulate the synthesis of neurotransmitters, which we know tend to be deficient in mood states. Other important facts: there are deficiencies in the enzyme methylene tetrahydrofolate reductase, MTHFR, as it's also called, which can result in depression, or so it's thought. And so, again, SAMe can be very helpful to people who have this deficiency, which occurs in about 10, 11% of the population. SAMe, like St. John's wort, is well studied. There's more than 50 published clinical trials using oral, intramuscular, and intravenous forms of SAMe. Doses have ranged from 200 to 3,200 milligrams a day. By and large, the studies support SAMe as more effective than placebo and about equivalent to tricyclic antidepressants. There's been one major meta-analysis and a recent systematic review that I was honored to be a part of. And our group was the first one to compare SAMe against an SSRI. So we recruited 189 patients, treated them for 12 weeks with SAMe at doses from 1,600 to 3,200 milligrams a day versus escitalopram 10 to 20 milligrams a day against placebo, so a 3-arm study. We found no significant difference in any other treatment arms. Everyone got better, basically. There was obviously a high placebo response rate, and that limited our capacity to really come to a full conclusion about SAMe. A couple of interesting findings. Men tended to respond better than women. There are some precedents in the literature for a differential response between the sexes. We also found that patients generally did better at the higher dose than at 1,600 milligrams. So it's important to be mindful of the fact that your patient may need higher doses to get the full effect. Other interesting studies that have come out of our group included combinations with different antidepressants. Jonathan Alpert first did a small study comparing the addition of SAMe versus, actually, no, this was an open study. Patients were given SAMe in addition to an SSRI that they were not responding to at the beginning. And after 6 weeks, benefit was shown. George Papakostas followed up on this study with a double-blind randomized trial in 73 non-responders to SSRIs and SNRIs. They were treated for 6 weeks with SAMe 800 milligrams twice daily or placebo. The study showed a significant advantage for SAMe. We have some data that we still haven't published that combining SAMe plus escitalopram also produced better results than either treatment alone or placebo. So this suggests that SAMe can be safely and efficaciously combined with standard antidepressants. So in terms of overall recommendations, the data are encouraging. The dose range is quite large, as you see. As far as side effects, they're mostly gastrointestinal in nature: nausea, loss of appetite, constipation. Those were the most commonly reported in all of our studies. And there's some others: insomnia, dry mouth, and so forth. As with St. John's wort, we've seen some cases of mania and hypomania in people with bipolar depression, so beware in this patient population. As far as pregnancy, it's known that pregnancy actually reduces methylation in SAMe levels. So in theory, SAMe could potentially be beneficial to pregnant women. There's at least one study in pregnant women who had intrahepatic cholestasis, and they were given SAMe with beneficial effects. So in theory, it could be beneficial for women who are pregnant and have depression, but we don't have a lot of safety data. So again, caution is suggested. One final caveat about SAMe: it's expensive compared to some of the other herbal remedies discussed here. So consequently, the buyer has to beware, and you should have that conversation with your patient about whether they can afford to pay out of pocket for it. Next, let's talk about the omega-3 fatty acids, which are a major part of my research portfolio. So the two omega-3s, which actually omega-3s are a family of various fatty acids. In psychiatry, we're interested in docosahexaenoic acid, or DHA, which you see here, and icosapentaenoic acid, or EPA, you see here. They are both long-chained fatty acids with many double bonds, and they're found primarily in fish oil and also in other marine sources like certain types of algae. How do they work as potential mood enhancers? Well, many mechanisms have been suggested: G protein signaling inhibition, stabilization of neuronal membranes in the brain, and also anti-inflammatory effects. There's about 30 or more randomized clinical trials in depression, mostly as adjunctive treatment to standard antidepressants, less so in terms of monotherapy. Typically, most studies use either EPA alone or a combination of EPA plus DHA, typically at 1 to 2 grams per day. A meta-analysis from 2011 suggested that EPA should be the dominant omega-3. The preparations with at least 60% EPA relative to DHA seem to be the most effective. As far as DHA monotherapy, there's very little direct evidence in terms of how DHA fares on its own. We did some studies that suggested it was beneficial at 1 gram a day. Marangel and colleagues did another study in which they found more efficacy at 2 grams a day. Our dose finding study indeed suggested that 1 gram a day or lower dose was more effective. Lewis and colleagues suggested effects in preventing suicide in the military population. Other work from our group has suggested that EPA may be more effective in people who are overweight and or have elevated inflammatory activity at baseline, presumably because of the anti-inflammatory effects of the omega-3. I've collaborated with Dr. Olivia Okereke on a large study in which we examined preventive effects of omega-3 in older people. That paper was recently published in JAMA. And as it turned out, we didn't find a significant preventive effect overall, but there were certain dimensions that seemed to improve. So I think the jury is still out on omega-3 as a potential preventive agent. Other potential applications, the omega-3s have been studied in postpartum depression. These studies are limited by small samples, so we need probably larger scale studies. As far as bipolar illness, early studies were very promising. More recent studies suggest overall that the omega-3s are probably best for the depressed phase of bipolar illness rather than for the manic phase. There's some possibility of preventive effects in psychotic disorders. Certain symptoms of borderline personality disorder may improve. There's also been studies in children and adolescents with promising results, some benefit in attention deficit disorders and little evidence for benefits in dementia. So it's been studied in a number of conditions. Data overall are difficult to interpret. There have been several meta-analyses that overall have shown mixed results. Some of the problems include a wide variety in terms of the studies, what preparations they used, what doses, and how the studies were designed. And we don't have head-to-head studies with different preparations. So there's still a lot of questions to be answered. As a synthesis, I offer that for depression, 1 to 2 grams a day of a DHA and EPA combination with EPA, the dominant omega-3, might be a good place to start. Bipolar disorder may require higher doses, sometimes as high as 6 to 10 grams a day, but we need to watch out for cycling, which has occurred. Side effects tend to be mild. Stomach upset and fishy taste are the most common. Current preparations are more highly purified, and these complaints are less common now. There were initially some concerns about an increased risk of bleeding, but recent studies have suggested that these concerns about omega-3 causing bleeding could be exaggerated. Nonetheless, it's still advised that, for example, if you're going to have surgery, you should discontinue omega-3 products at least a few days or even a week or more before undergoing the surgery. As far as expectant mothers, we know that the omega-3s are important for the development of the fetal brain. In fact, pregnancy typically depletes all omega-3 or most of it from pregnant women. The FDA has approved fish consumption during pregnancy, so there's reason to think that taking omega-3 supplements would also be potentially beneficial and harmless. But we don't know what the safe upper limit of dosing would be in a pregnant woman or in breastfeeding women as far as the safety to the infant. So again, we still advise caution. Now, let's move to other herbal and natural remedies that are thought to have applications in more wider ranges of indications. Rhodiola rosea is a plant that is found in the mountains of Europe and Asia. It's been a staple in traditional medicine in Asia, Scandinavia, and Eastern Europe. It's thought to function as what we call an adaptogen, which means it stimulates the body's own natural resistance to different kinds of stressors. It stimulates the nervous system and may enhance physical and mental performance. It's been helpful for preventing altitude sickness in some studies, and other things improve with it: fatigue, stress, depression, and sexual dysfunction. Rhodiola has been studied extensively in Russia and Scandinavia for a long time. Unfortunately, most of those reports have not been translated to English. So many of us who are not literate in Russian or Scandinavian languages have to settle for those that have been translated. One of those studies told us there are thought to be multiple active ingredients in rhodiola. The more relevant ones are the adaptogens, rosavins, and tyrosols. There are also antioxidants. There's some monoamine modulation in MAOA and B inhibition, and opioid-like effects among other chemical effects. At least 4 controlled trials have supported efficacy in depression and anxiety, as well as promoting cognition. The doses typically recommended are between 100 and 680 milligrams per day. A more recent trial of rhodiola for major depressive disorder was very interesting. They recruited 100 patients with mild to moderate depression, and they were randomized to one of three treatment arms, either sertraline at high dose plus placebo, sertraline plus rhodiola 600 milligrams a day, and sertraline plus rhodiola at 300 milligrams a day. All of these groups showed statistically significant reduction in various scales, including the Hamilton Depression Scale, the Beck Depression Inventory, and the Clinical Global Improvement Scale. Group B did the best compared to groups C and A. So this suggests that the higher doses of rhodiola might be the best choice for people with major depressive disorder. As far as safety concerns, side effects tend to be mild and they don't occur too often, but we need to be cautious, particularly at higher doses. So allergic reactions have occurred, and there have been some cases of irritability and fatigue and other unpleasant sensation. Insomnia or vivid dreams have been reported, so it's advised to take it early in the day and preferably on an empty stomach before meals. Rhodiola doesn't seem to interact with other drugs. In fact, in some studies, it was combined with tricyclic antidepressants safely, and they even dampened some of the side effects from the tricyclics. We don't know much about safety in pregnancy, and we know of no reports of bipolar cycling, but nonetheless, it should be used with caution in both these populations. Another potentially multi-use natural remedy is inositol. Inositol, which you see on the bottom right of the slide, it's a sugar alcohol structurally similar to glucose, and it's found primarily within the cell membranes. It can be obtained in the diet in beans, grains, nuts, and various fruits. An average adult consumes about 1 gram a day. For anybody interested in little trivia, it's also called vitamin B8. It's important in second messenger systems. It interacts with these and impacts on neurotransmitter receptors. As we see here, it's thought to be involved in the phosphatidylinositol cycle, which we know is relevant, for example, to the management of bipolar illness. We know that lithium, for example, is thought to interact with the system, so there can be analogous activity from inositol. As far as efficacy, it's not as well studied as some of the other products I've talked about. There's about 6 clinical trials for depression, at least 5 placebo-controlled, and these include monotherapy and augmentation. Some of them include mixed populations, unipolar and bipolar depression. By and large, inositol outperformed the placebo in most of these studies, but only one study actually reached statistical significance, and the samples in all of these studies were relatively small, so that limits statistical power. Other applications have included panic disorder, obsessive compulsive disorder, and bulimia nervosa. This suggests that the spectrum of action of rhodiola could be similar to that of the serotonin reuptake inhibitors, which we know can treat all of these conditions to varying degrees. Inositol has not been shown to be effective for schizophrenia, ADHD, Alzheimer's disease, autism, or for ECT-induced cognitive impairment. As far as safety and side effects, mild increases in plasma glucose have been reported. Other GI disturbances and sleep disturbances have also been reported. There have been cases of mania in people with bipolar depression. On the other hand, no serious toxic reactions or interactions with other drugs. It's not recommended in pregnant women because there is a danger of inducing uterine contractions prematurely. So definitely do not recommend it to a pregnant woman. In terms of dosing, these may vary from 6 to 20 grams a day. Typically for depression, we may use about 12 grams a day, divided at a regimen of 2 to 4 times a day. For OCD, it may require higher doses, as we see with SSRIs. Okay, now let me say a little bit about L-methylfolate or Deplin, which is not really alternative anymore in the sense that this is an FDA-approved vitamin. However, it's only approved for supplementation in the vitamin deficiency, not for depression per se. So L-methylfolate is basically a product of folic acid. As we see, if we obtain folic acid in synthetic form or in the diet, it has to undergo a variety of conversions, including one involving MTHFR, which I mentioned earlier, until it becomes L-methylfolate, which is the most biologically active form, and it's the only form that can cross the blood-brain barrier. So basically, if we give someone L-methylfolate, you bypass any polymorphisms that may affect folate metabolism, MTHFR, and others, and it can go directly into the brain. So as a potential treatment for depression, it's very compelling. Our group carried out a clinical trial in major depressive disorder with L-methylfolate. George Papakostas was the principal investigator on it, and he recruited adults with MDD, and they were required to have a quiz self-rated score of 12 at least for screening and baseline, indicating a degree of mild to moderate depression. These were people not responding to SSRIs for at least 8 weeks, and it was a fairly large study with multiple centers, and these people received either 15 milligrams a day of L-methylfolate or placebo. What I show you here is that change in some of the depression scales. So we see with L-methylfolate in orange versus placebo in gray, there was a greater improvement in the Hamilton scale, the 17-point scale and the 28-point scale, which reached significance, and also the QIDS scale. The differences reached significant, and the CGI improvement scale. So all of these were encouraging in terms of the efficacy of methylfolate. Okay, let's move on now to the more anxiolytic spectrum remedies. Let's start with Kava. So Kava, or Kava, as it's also called, originated in the Polynesian Islands, and it's used in various tribal rituals. It's not as well studied as some others. There's at least 12 or more studies that are pretty good. Overall, they suggest efficacy for generalized anxiety. No data really on panic disorder. Recommended doses range from 60 to 300 milligrams a day. My colleague Jerome Saris, who's an Australian doctor who trained in our program for a while and now directs his own research program at the University of Western Sydney. He recently published a 16-week study in 171 people with generalized anxiety disorder, and he didn't find benefit of Kava at 120 milligrams twice daily. So I think we need more work on Kava. Some safety concerns. There's a condition called Kava dermopathy, which is a temporary yellowing of the skin that can occur. Usually that's reversible if you just stop taking Kava. There have been more serious concerns about liver toxicity developing, and even some cases of death. For a while there, Kava was taken off the market in many countries as a result of this. More recent evidence suggests safety that the reason for the toxicity had to do with impurities that developed upon fermentation due to poor manufacturing standards. Kava is still available in the US and in other countries, but we advise caution when using it, preferably for short periods and if for longer periods with regular monitoring of liver functions. Next, Valerian, or Valerian officinalis. This is another popular herbal drug that's been documented to be in use for over 1,000 years. It's a popular sedative and mild hypnotic, and works primarily through GABAergic compounds, in particular valipotriates and sesquiterpenes. As far as its efficacy, there's more than 40 controlled trials that have recruited not just symptomatic individuals, but also healthy subjects to determine how well it promotes better sleep. 7 studies in which Valerian was compared against benzodiazepines suggested comparable efficacy as far as reducing sleep and fewer side effects, um, and no issues with tolerance. However, there have been some recent meta-analyses that have not been as encouraging, mainly because of the limited rigor of some of these studies. Some studies have suggested benefit in children and the elderly, populations that may be particularly vulnerable to benzodiazepine side effects. Other benefits have been proposed in menopausal women, as well as in obsessive compulsive disorder. One of the limitations of valerian, it has a very powerful smell that resulted in unmasking of the blind in some of the earlier studies. Current preparations include some of valerian's inactive ingredients in the placebo that give it a similar smell. So I expect that newer studies will probably be of better quality. As far as dosing, valerian is typically dosed between 450 and 600 milligrams about 2 hours before bedtime. There doesn't seem to be benefit from taking higher doses. The effect is not as acute as you might see with a benzodiazepine. What it seems to do is improve sleep gradually over the course of a couple of weeks. So remind your patients that they need to give it a fair chance. Other advantages: no morning after hangover, no complications in overdose. There are a few cases where patients were fine, and no interactions with other drugs, so it can be combined safely. The most common complaints you might hear about in practice are headaches and GI complaints. There have been some rare toxic reactions that have been reported: blurry vision, dystonias, liver problems, and one case of withdrawal and delirium occurring. These are very unusual. While you want to keep them in mind, it's unlikely that you might see them in your practice. So overall, valerian appears to be a promising hypnotic, which can get people to sleep faster and maybe improve overall sleep quality. While studies suggest comparable efficacy to benzos, it's probably not optimal for acute treatment of very severe insomnia where the patient may be looking for more rapid relief. So use your judgment as to who might be a good candidate for it. No problems with daytime drowsiness or dependency. Safety in children and the elderly also a plus. There have been some retrospective studies where women were asked about what natural supplements they may have taken during pregnancy. Many have reported valerian with no complications, but we really don't have prospective data, so as always, caution. And next, melatonin. So melatonin is a hormone that over here that we all manufacture in the pineal gland of our brain. It works primarily as a sleep inducer. It's especially popular with people who travel to different time zones because it helps to reset their circadian clock. There's about 20 studies with it, some in children and the elderly as well, with promising results. They even have a prolonged release form that can give you more even effects during the course of the night. It's been studied in elderly people with good results. Various meta-analyses of melatonin examining its efficacy have emerged. All of them, colleagues examined 12 double or single blind randomized trials. By and large, melatonin outperformed placebo in a number of sleep parameters. Another meta-analysis by Rhodiola colleagues examined 19 trials. Again, overall, the meta-analysis suggested benefits in various dimensions of sleep. So very, very important. How does it work? It's thought to work by resetting the circadian rhythm because melatonin is typically secreted at night. So essentially, it will give a boost to the person who wants to sleep. And there's also some direct sedative effects. In terms of safety, there have been some rare side effects reported, problems with fertility, decreased sex drive, body temperature dysregulation. one case of retinal damage, and another concern about potential immunosuppressive effects. We do advise caution in HIV patients or anybody else who's immunosuppressed. We don't know much about safety in pregnancy, so again, caution is advised. As far as dosing, a lot of people do well with low doses between 0.25 and 0.3 milligrams a day. You will note that some commercial preparations may have up to 5 or sometimes even 10 milligrams. There have been cases of daytime sleepiness or even confusion caused by high doses. So I recommend starting with a low dose and then increasing gradually over a few days if you're not getting the results you want. And again, it's been studied in children and in the elderly, and the results are encouraging, although many studies are small. It could be a good alternative to benzos in these populations. All right, now next I'll talk about CBD or cannabidiol, which is a drug that is getting a lot of press lately. So what is CBD? So it's a constituent of cannabis or marijuana, one of at least 113 such cannabinoids. And in hemp extract, it may represent up to 40% of it. It was actually discovered in 1940, and at first it was not thought to be pharmaceutically active, so it was not really pursued until the recent years. How do people obtain it? It can be inhaled through marijuana smoke. It's also sold in vapor forms, aerosol sprays, and also in oil forms. One of its most popular preparations is as an oil that contains pure CBD as the active ingredient. So there's no THC or terpenes or other marijuana-related chemicals. And it may also be provided in capsules or a prescription liquid solution in other ways. Now, actually, CBD is approved for certain indications in certain countries. In particular, for multiple sclerosis pain, there's a preparation called nabiximols or Sativex, which is approved in Canada and in Sweden. In the United States, it's approved for certain childhood epileptic disorders, in particular Lennox-Gastaut syndrome and Dravet syndrome. But that's it. We don't have a whole lot of data on other potential indications. How does it work? Well, it's thought to be a low affinity indirect antagonist or blocker of the CD1, cannabinoid 1, and CD2 receptors. It may potentiate THC effects by increasing the density of cannabinoid receptors. It also interacts with G protein coupling receptors in different parts of the brain. It interacts with serotonin receptors, which could explain some mood enhancing effects or anxiolytic effects. It also interacts with mu and delta opioid receptors, and it has other functions as well. PPAR antagonism. It may affect intracellular calcium release and also interact with fatty acid related enzymes. So a lot of things that CBD may do. Side effects tend to be mild. Sleepiness, decreased appetite, diarrhea, and other things of the sort. There are no intoxicating effects documented. In fact, there's some evidence that it might oppose disordered thinking and anxiety that THC may produce in some people. In the US, as I mentioned, it's considered a Schedule I drug, but it is approved for those childhood epilepsy disorders I mentioned. It's currently sold openly in most states. There's probably a CBD dispensary in your town, depending on where you're from. By and large, I caution my patients that while it's probably safe, we don't know a lot about what potential long-term adverse effects may occur, and we don't really know much about its efficacy in psychiatric conditions. As a little bonus, I'm going to mention Ginkgo Biloba, which is neither antidepressant nor anxiolytic, but potentially useful in the patient who has cognition-related problems. It's been studied extensively in Alzheimer's dementia, and most of the studies are supportive. Active components include flavonoids and terpene lactones, functions in various ways by stabilizing neuronal membranes and free radical scavenging. Various meta-analyses and systematic reviews support it. It's been compared against cholinesterase inhibitors, the standard of care in dementia. By and large, the cholinesterase inhibitors have an advantage in efficacy, but ginkgo wins in tolerability, and the two can be combined. So taking one doesn't rule out taking the other. No evidence that ginkgo can prevent dementia in people, say, who have a family history of dementia. They were to start taking it early before they get any symptoms. We don't really know if that can happen. Doses of ginkgo run from 120 to 240 milligrams a day, typically best for Alzheimer's and less so for vascular dementias. Not surprisingly, the earlier you start, the better. Full assessment of effect may require 1 year of follow-up, but we don't know much about the long-term trajectory of Alzheimer's and the longer-term course of ginkgo. Another potential niche for ginkgo, it has been shown in some small studies to alleviate antidepressant-induced sexual dysfunction. In terms of tolerability, most side effects are mild, stomach upset, headache, irritability. There have been some questions about it increasing the risk of seizure in people with epilepsy, but other studies have suggested it may actually decrease it, so it's hard to say. The other concern about ginkgo is that it inhibits platelet activating factor involved in clotting, so it should not be taken if you're taking anticoagulants or if you're having surgery. That said, a recent meta-analysis that examined studies where they looked at hemostatic outcomes, there didn't seem to be an increased risk of bleeding. On the other hand, inhibition of platelet activating factor can increase the risk of bleeding in pregnancy. And likewise, we don't know the risk to breastfeeding infants. So again, in the pregnant or breastfeeding woman, we advise caution. To synthesize all these data, I'm mentioning here the CanMet recommendations. These were put together by a group in Canada that published them in 2016. They looked at various natural and alternative remedies, and they gave a first-line recommendation for St. John's Wort as mild to moderate ED. They gave a second-line recommendation for omega-3 and also for SAMI. Some of the other things mentioned here were not as popular because the data are just simply less encouraging. While this was not part of the talk, I want to mention the CanMet group also supported exercise and light therapy as first-line treatments for mild to moderate depression and for seasonal depression, respectively. Other treatments, yoga, acupuncture, were also mentioned as second and third line treatments. So those are also up there for consideration. To conclude, the patients that I might steer towards natural remedies of the type mentioned here are those people who may have mild illness and a strong interest in trying natural remedies rather than a registered drug, and who don't mind paying out of pocket for it. These people don't have much to lose by trying. At the other end of the spectrum, there's the patients who have tried most everything that's on the market and approved and either didn't respond or had a lot of side effects. These patients may also have nothing to lose by trying these treatments, but I caution that these are difficult to treat patients, and most of the literature supports these natural products for mild to moderate depression, less so for more severe or treatment-resistant depression. As always, be cautious with pregnant or breastfeeding women, and also be careful in the patient who's taking multiple medications, because there are, with some of these drugs, concerned about drug-drug interactions or drug-herb interactions. Okay, so that brings us to the end. We have time for questions. If we run out of time, I offer my email address here in case any of you want to write me with your questions. I'm always happy to hear from people. I answer all questions that are sent to me, and I often learn something new from some of these questions because you may know of some product that I haven't had the chance to learn about yet. So thank you all for your attention, and we'll take some questions.
Thank you so much, Dr. Michelon. We do have a few questions that have come in. I'll start with one. Do you have any recommendations for brands of herbs that are more reputable and that they do more testing on potency?
Yeah, thank you. I get that question a lot. Now, as a general policy, I don't like to endorse specific brands, especially when I'm being recorded. What I do is tell people the following. When I recommend some of these preparations for my patients, I usually will mention brands that we have used in some of our own studies and that have been used in other studies, particularly those that are registered on clinicaltrials.gov. Why do I do this? Because usually most funding agencies will require some sort of vetting of these products. For example, our last study of omega-3, we actually had to have 2 independent labs verify the purity of the omega-3 preparations we were using, not only the contents, but also whether there was any oxidation-related degradation. What this means basically is that these products that are used in clinical trials are probably of strong quality, that what you read on the label probably reflects what's in the capsule or pill. Mm-hmm. But there's no guarantee that they're quote unquote better than some other no-name brand that you might find at CVS or at any other drugstore. In general, the brands that are sold in drugstores are probably come from pretty reputable sellers. I caution people who go on the internet and buy from some of these places that no one's heard of. Don't get seduced by lower prices or outlandish claims that some of these sellers make. But I would tell the clinician, go to clinicaltrials.gov and look up the information of some trials of the product you're interested in, because they have to list who provided the preparation. And that's a good way to recommend a good, solid quality brand for patients.
I think that makes sense. It was a good political answer. We got a question from an attendee. It goes, any benefit to 5-HTP and or it's either GABA or GABA?
Sure. 5-HTP, 5-hydroxytryptophan, is the best studied of those 3 products. So I can comment probably with more detail on that. 5-HTP was actually very popular. It's a precursor to serotonin. And in the 70s and 80s, it was actually studied widely for depression. And then what happened? Well, basically in 1987, Prozac arrived on the market, and shortly after other SSRIs, the serotonergic antidepressants, followed. And pretty soon there was a loss of interest in 5-HTP because we already had some approved serotonergic drugs on the market. Another problem is that there were some medical complications that developed with 5-HTP, which turned out to be not directly related to HTP itself, but rather to, again, impurities due to poor manufacturing standards. For that reason, HTP was actually taken off the market for a while. But after further research established safety and better manufacturing standards we put in, 5-HTP is back on the market. Despite that, there hasn't been any renewal of interest in 5-HTP, which is a shame because the early studies were promising. They suggested benefits in depression with good efficacy and tolerability. So I think 5-HTP deserves a second look. The other agents, are less well studied, and those I'm more likely to recommend with caution.
Got it. Thank you. We do have 2 questions on melatonin. So the first one is, for insomnia, what are your thoughts for supplements that combine melatonin with valerian root, magnesium, etc.? And then an additional question was kind of about the dosing of melatonin and how it might react with children versus adults. So there's a lot there.
Okay, so let's start with the combination. Well, as I mentioned, these particular remedies don't seem to have significant interactions with other drugs or other natural products. So from that standpoint, they can be combined safely without major risk. The concern about combining two sedatives together is that the effect could prove to be too strong for certain individuals. So I think the way that I might consider using a combined preparation like that would be, once I've established the effects of the two independently, and if it's decided that the combination of the two seems to work best, say if a patient can only tolerate so much melatonin or only so much valerian, but they can't get the full benefit from either one, the combination would be worth trying at that point. What you want to watch out for is excessive sedation during the day. The other question about the studies in children, by and large, the studies in children were interesting. They tended to recruit children who had some developmental and behavioral difficulties, not insomnia per se as the chief complaint. And what they found is that melatonin helped with the sleep component of their presentation, not so much in any of the behavioral components, which you might not necessarily expect to happen given everything we know about melatonin. With children, obviously, you're probably going to dose them lower than adults. So a typical melatonin preparation, as I was saying, will start at about 0.25 to 0.3 milligrams. So I would say with a child, that's probably where you want to start. And then you can increase the dose gradually depending on how the clinical effect is established. The same principle applies in older people. Start low, go slow, because older people may be more sensitive to side effects. So if you follow that same principle with older adults, you'll be on very solid ground.
Okay, thank you so much. We have an additional question that was if you had any further comments on magnesium supplementation.
Yeah, magnesium supplementation as well as other ions have been used in mood disorders, but and anxiety disorders as well. But there's just not a lot of solid data to recommend them. I have many patients who take magnesium supplements, as you might expect for constipation, as you might have in milk of magnesia or in magnesium caplets, and certainly they find them very helpful in that regard. None of them have particularly endorsed any changes in mood or anxiety symptoms as a result. So I'm not quite sure what the place is for magnesium supplementation. I think it may merit some further study, but I'd like to see some more preliminary data before diving into a large clinical trial.
That makes sense. Thank you. We had a question there. They just keep coming in, so we'll answer a few more before we wrap up. Can you please reference the study sorry for my pronunciation of this, Inositol?
Inositol.
Yeah, for OCD.
Sure. This was a study done by Robert Bellmacher, Belmaker. Dr. Bellmacher leads a lab at the Weizmann Institute in Israel. And in fact, for most of these studies that I mentioned came out of that lab. So they published a large number of studies. You can find them on PubMed on inositol in various different indications. So I have cited this work widely because really very few other groups have sought to replicate their findings. The main limitation of that work, as I mentioned, is that they tend to have small samples. So consequently, these studies need to be interpreted with caution because they often don't have the statistical power that you need to make a confident recommendation about them. I'm a little surprised that they never followed up on this work with larger studies. It's possible that they had difficulty obtaining funding from their agencies. Certainly getting money for complementary therapies does have its challenges. But yeah, I mean, if you look up Bellmacher's work, that would be the vast majority um, of work about inositol. A little self promotional plug. We have a book that we published in 2008 on natural remedies in psychiatry. The book is still in print. It's somewhat out of date, as you might imagine. It was more than 10 years ago. However, there is a chapter written by Bellmacher himself in which he gives a beautiful synthesis of all this work. So if you're interested, you can look up the book. It's available on Amazon, and you can pick up a copy. And that might give you, a good understanding of how inositol may be used.
Okay, and because I am conscious of time, we'll take one last question. What other sources of omega-3 besides fish oil might you suggest, since they may contain mercury?
Sure. The mercury issue is probably no longer a major concern. Most of the salmon that are used for obtaining the fish oil are farm grown these days. So this was due to obviously commercial considerations, concerns about overfishing, and obviously concerns about safety and pollutants. And many of these preparations are now ultra distilled. So really, you're getting as pure a product as possible. So from a safety standpoint, if you buy from a reputable maker, some of the brands that we've used in our study are those that are quite highly purified. Now, what about other sources? This is a question I get because from time to time, I may have patients who are vegetarian or vegan and do not want to consume anything that comes from an animal or fish, bird, whatever. And what I recommend is there are some omega-3 preparations that come directly from the algae. I had mentioned that, the omega-3s may be found not just in fish, but in algae. And there are commercially available preparations that have DHA, EPA, etc. From plant sources. So that's one option for the vegan or vegetarian patient who is very strict about what they want to consume.
Okay, thank you so much, Dr. Michelon. I think this was a great session. We had a lot of great questions. So thank you to all of our participants for joining us today. If you are not yet an ADAA member, we invite you to join ADAA to attend sessions such as this at no cost, which I think is a wonderful benefit. And if you have any further questions, please feel free to email Dr. Michelon or email webinars@adaa.org. Thank you so much.
Thank you, everyone.